Hello everyone. Now we are going to discuss about a new chapter, inflammation. So what is inflammation? By definition, inflammation is a response of vascularized tissue that deliver leukocyte molecules of the host defense from circulation to the site of infection or damage in order to eliminate the offending agent. Basically, it's a response of vascularized tissue in the form of delivering leukocyte and different molecule at the site of injury or infection to remove this offending agent. What are the causes of inflammation? So causes of inflammation, there are numerous causes of inflammation. Broadly, they can be infection like bacterial, viral, fungal, parasitic infection or microbial toxins. Tissue necrosis may elicit inflammation. Foreign body like splinter, dirt, suture, etc. may also result into the inflammation, and immune reactions may also result into the inflammation. Although there are numerous reasons can be culminate into the inflammation, we will see later on. The sequence of events in an inflammatory reaction. So what are the events occur in an inflammatory reaction? First of all, a microbes or an infective agent or a tissue necrosis will be there. They are recognized by tissue resident macrophages or known as sentinel cells. For example, macrophages, dendritic cells and mast cell, they recognize these necrotic tissue or infective microbes. After the recognition, they release various mediators and which result into the various action. First, they recruit the leukocytes, mainly neutrophil and macrophages. They release some plasma protein like complement and kinin, and by the release of the mediators, there will be vasodilation and increased vascular permeability, which result into the swelling or edema. The recruitment of leukocytes and plasma protein like complement and kinins, they will result into the elimination of the microbes or dead tissue. After the release and removal of these microbes and dead tissue, the cytokines of the later phases and growth factor will result into the repair. Inflammation are broadly divided into acute and chronic type. We will see the basic differences between these two. Onset in acute inflammation is in minutes or hours, although in chronic inflammation it takes days or longer duration. Cellular infiltrates mainly in acute inflammation is neutrophils, and in chronic inflammation mainly mononuclear cells like monocyte, macrophages and lymphocytes. Tissue fibrosis. In acute inflammation, usually mild and self-limiting tissue injury or fibrosis is there, but in chronic inflammation often severe tissue injury or severe and progressive tissue injury and fibrosis is there. Local and systemic signs. Usually local and systemic signs like swelling, fever, pain are more prominent in acute inflammation and less commonly seen in chronic inflammation. In the next lecture we will discuss about the acute inflammation in detail. Thank you. Hello everyone, now we are going to discuss about the acute inflammation. Acute meaning sudden onset. So the onset in acute inflammation is from a few minutes to few hours. There are three major components of acute inflammation: vasodilation of small vessels, increased vascular permeability, and immigration or recruitment of the leukocytes. So these are the three major components: vasodilation, increased vascular permeability, and leukocyte recruitment or immigration of leukocytes. So now we will see the various reaction of blood vessels in acute inflammation. First is vasodilation. Mediator for this vasodilation is histamine. Due to vasodilation, there is increased blood flow or stasis of blood due to the vasodilation. The second reaction of blood vessel is increased vascular permeability. Increased vascular permeability. There are two mechanisms of increased vascular permeability. One is by the contraction of endothelial cell. As we know, the blood vessel is lined by endothelial cell. Whenever there is contraction of these endothelial cells, there is increase in the interendothelial gap and result into the increased vascular permeability. This mechanism is usually mediated by various cytokines or various mediator of inflammation like histamine, bradykinin, and leukotrienes. Another mechanism of increased vascular permeability is direct injury to the endothelial cells, which can be seen in thermal injury. Third reaction or response in blood vessel is responses of lymphatic vessels and lymph nodes. The fluid that accumulate in or produced during the inflammatory process is known as exudate, and this excessive exudate drain into the lymph node with the help of the lymphatics. This fluid carry leukocytes along with microbes, and this accumulate into the lymph node. As this is of infective etiology, this may result into the lymphadenitis or reactive hyperplasia. So this is usually noted in the inflammatory condition that adjacent lymph nodes are swollen or painful because of the drainage of this exudate into the adjacent lymph node. Now we will see the leukocyte recruitment to the site of inflammation. How leukocyte recruit or reach at the site of inflammation. The major leukocyte we will discuss or involved in the acute inflammation are neutrophil and macrophages. There are series of events before a leukocyte reach at the site of inflammation. First is margination. In the margination, normally blood cells flow inside the blood. Normally they flow in the midstream, but in inflammation they start marginating or start leukocyte toward the periphery of the blood vessel near the endothelium. After this margination, they start rolling with the help of selectins. Selectins are the protein. There are three types of selectin: L-selectin present on leukocyte, E-selectin present on endothelial cells, and P-selectin present on the platelets. After this rolling, there is adhesion of leukocyte with the endothelium with the help of integrins. There are mainly two types of integrins, B-chem and I-chem. After the adhesion, these leukocytes transmigrate across the endothelium. This process is known as diapedesis. That transmigration of leukocyte across the endothelium into the interstitium, and PCAM1 or CD31 will help in this process. Now once these cells or leukocytes in interstitium, now they reach to the site of injury or site of inflammation with the help of chemotactic signals. Chemotactic signals released by the various macrophages or microbes to attract the cells at the site of infection or inflammation. Now before going further, we need to understand or discuss about the selectins or integrins. The selectins, as we have seen, selectins are help in rolling process of inflammation. There are three types of selectin: L-selectin present on the leukocyte, E-selectin present on the endothelium cells, and P-selectin present on the platelets. Whenever there is a syndrome known as Cialin-Lewis syndrome or disease in which there is deficiency of selectins. Integrins are the proteins that help leukocyte to adhere with the endothelium. LFA1 integrins are present on neutrophil or monocytes. MAC1, VLA4, alpha 4, beta 7, these three integrins are present on the monocytes. So monocyte has all the integrins and neutrophil has only LFA1 integrin. As we have seen, the process of chemotaxis, when the site cells or microbes present at the site of injury attract the leukocyte in the interstitium, this process is known as chemotaxis, and there are some chemotactic agent, could be exogenous or endogenous. Exogenous chemotactic agents are bacterial products, for example N-formylmethionine, and endogenous chemotactic agents, mnemonic LIC used for them: L for leukotriene B4, I for interleukin 8, and C for C5a complement protein. This is a diagrammatic representation of the process of leukocyte recruitment. First of all, as we can see, this is the margination of the leukocytes from midstream to the periphery. Then we can see the selectins are over here. They help in the rolling process. After rolling, the leukocyte adhere with the help of integrin to the endothelium. This is the adhesion. After the adhesion, leukocyte transmigrate across the endothelium, and this process is known as diapedesis. Once the leukocyte is in interstitium, they follow the chemotactic signal released by the macrophages of the microbes and reach to the site of the infection or inflammation and result into the further phagocytosis of this microbes. Okay, now we will discuss about the phagocytosis and clearance of that offending agent. Two main types of phagocytes involved in acute inflammation are neutrophil and macrophages. So what are the steps involved in the phagocytosis? First of all, a phagocyte recognize the offending agent, attach with it recognition attachment of the particle to be ingested by the leukocyte. So first of all, phagocyte recognize an offending agent by various receptors. After this, there is an engulfment of this offending agent by the formation of phagocytic vacuole, and after this phagocytic vacuole formation, there is a killing of microbes by various enzymes. So what are opsonin? One important terminology is opsonin. What are opsonin? They basically increase the affinity for phagocytosis. They are coated microbes. They coat the microbes and increase their affinity for the phagocytosis. Examples of opsonin are IgG, C3V, mannose binding lectin, colectin. Leukocyte has various receptors for recognition of microbes or these degenerated particles to be phagocytosed, like G protein coupled receptor, toll-like receptor, cytokine receptor, and phagocytic receptor. After the recognition, they send a various signal and ultimately result into the inflammatory reaction or killing of the microbes. Now we will see about the phagocytosis and intracellular destruction of the microbes. As the phagocytic cells has receptor for the microbes, they recognize the microbes, then they start engulfment of the microbes and then form a phagosome. Phagosome has the microbe inside the vacuole. This phagosome fuse with the lysosome and form a phagolysosome. And in this phagolysosome there is degradation of the microbes with the help of lysosomal enzyme. How these lysosomal enzyme degrade these microbes? So in a neutrophil, there are a principal mechanism for degradation of these microbes or bactericidal system, H2O2 MPO halide system, which form a free radical of hydroxyl and chloride, which result into the destruction of bacteria or microbes by free radical injury. In macrophages, arginine is converted into the nitric oxide by inducible nitric oxide synthase and result into the formation of nitric oxide. Nitric oxide by combining with superoxide free radical form the peroxynitrate free radical, which causes free radical injury to the microbes. Now we will see about the various granules of neutrophils. As neutrophil is the principal leukocyte involved in acute inflammation, we will see the various granules of neutrophil. There are two main types of granules in neutrophil: primary or larger azurophilic granules, secondary or smaller specific granules. So primary azurophilic granules has MPO myeloperoxidase. They have bactericidal proteins like lysozyme, defensin, acid hydrolases. Neutral proteases like elastase, cathepsin G, proteinase 3, non-specific collagenase. On the other hand, secondary granules has lysosome, collagenase, gelatinase, lactoferrin, plasminogen activator, histaminase, and alkaline phosphatase. These various enzymes are responsible for the various function of neutrophil. Now we will discuss some of the enzymes and their function. Acid proteases, responsible for the degradation of bacteria and debris inside the phagolysosome. Neutral proteases, they are responsible for the degradation of extracellular components like collagen, fibrin, elastin, etc., and they are responsible for the tissue destruction. Neutral proteases also cleave C3 and C5 and they release kinin. Neutrophil elastase is another enzyme which is responsible for the degradation of the virulence factor of bacteria. So this is very important in controlling the inflammation or infectivity of bacteria. There are some anti-proteases in the body. They control the harmful effect of proteases. For example, alpha-1 antitrypsin, alpha-2 macroglobulin. Alpha-1 antitrypsin is very famous. Alpha-1 antitrypsin inhibits neutrophil elastase, and in case of deficiency of alpha-1 antitrypsin deficiency, there is sustained action of neutrophil elastase and will result into the destruction of elastic fiber support, and this is seen in one of the very famous disease of emphysema in lung. And now we will see one more important topic related to this: neutrophil extracellular traps, NET. So in infection or inflammatory mediators, they stimulate neutrophils to form extracellular traps which consist of viscous meshwork of nuclear chromatin and concentrate granules protein. Viscous meshwork of nuclear chromatin and concentrate granule proteins, they make the extracellular trap, and this net basically trap the microbes and kill them. Net formation is via chromatin decondensation. So arginine deaminase convert arginine into the citrulline, and MPO elastase then enter into the nucleus and causes the further decondensation of the chromatin, and this will help into releasing of this chromatin outside the cell and trap the microbes. Next, when a neutrophilic extracellular trap seen in SLE, systemic autoimmune disease, in which this is a source of nuclear antigen. Leukocyte mediated tissue injury. If there is an inflammation or leukocytes recruit over there, then they will cause collateral damage to the adjacent tissue. They might cause an autoimmune disease or host react excessively, which is seen in hypersensitivity reaction. So this is the difference between neutrophil and macrophages, which we have already discussed in one of our video. There are certain anti-inflammatory cytokine which actually prevent or suppress inflammation, TGF beta and interleukin 10. So thank you for listening. In the next lecture we will discuss about the mediators of inflammation. Hello friends, now we will discuss about the mediators of inflammation. Inflammatory mediators are the substances that initiate and regulate the inflammatory reactions. They can be vasoactive amines, lipid products, cytokines, chemokines, complement products. Inflammatory mediators are mainly of two types: cell derived or plasma derived. In cell derived we have histamine, prostaglandins, leukotrienes, cytokines, and in plasma derived we have complement proteins and kinins. Active mediators are produced only in response to an offending stimuli, which can be microbial product or necrotic cells. Most of the mediators are short-lived. They vanish after their purpose served. One mediator can stimulate the release of other mediator. Products of complement activation, for example, products of complement activation stimulate the release of histamine and TNF cytokines. Some of the abbreviation we are going to use in this lecture: VC for vasoconstriction, VD for vasodilation, VP for vascular permeability. Now we will see various inflammatory mediators on the basis of their source of production and their action. Histamine is a vasoactive amine which is produced by mast cell, basophil and platelet, and act as a vasodilator, increase vascular permeability, and plays an important role in endothelial activation. Other inflammatory mediator is serotonin, also known as 5-hydroxytryptamine, produced by platelets and neuroendocrine cells of the GIT. Act as a vasoconstrictor or a neurotransmitter. Another class of inflammatory mediators are prostaglandins. Source of production is mast cell, leukocytes. Act as a vasodilator, plays an important role in pain and fever. Leukotrienes, produced by mast cell and leukocytes, act as a increase vascular permeability, plays an important role in chemotaxis, leukocyte adhesion and activation. Cytokines, for example, tumor necrosis factor alpha, interleukin 1, interleukin 6, they produced by macrophages, endothelial cells and mast cell. They act locally as an endothelial cell activation, in which endothelial cell express the various adhesion molecule, and in systemic action they are responsible for the development of fever, metabolic abnormalities, and have a role in hypotension. Chemokines, produced by leukocytes, activated macrophages, have an important role in chemotaxis, leukocyte activation, Platelet activating factors produced by leukocyte and mast cells. Their action is vasodilation and increased vascular permeability, responsible for leukocyte adhesion, chemotaxis, and degranulation. Complement products, they produce in liver and mainly they are plasma derived, responsible for vasodilation, chemotaxis, leukocyte activation, direct target killing. Kinins produced in liver, they are also a class of plasma derived inflammatory mediators, responsible for increased vascular permeability, vasodilation, important in the pain and smooth muscle contraction. Now we will discuss about one of the important class of inflammatory mediators known as arachidonic acid metabolites. Whenever there is mechanical, chemical and physical stimuli or some other mediators like C5a or complement, they are responsible for the production of arachidonic acid from the membrane phospholipid. Arachidonic acid is also known as icosanoid, a 20 carbon acid. It is derived from linoleic acid. So as we have discussed, arachidonic acid derived from the cell membrane phospholipid. Phospholipases act on this linoleic acid or membrane phospholipid, and there will be a production of arachidonic acid. Arachidonic acid, by the action of cyclooxygenase enzyme, converted into the prostaglandin G2, which further converted into prostaglandin H2, then prostaglandin I2, thromboxane A2, and prostaglandin D2 and E2. Prostaglandin I2, also known as prostacyclin, which acts as a vasodilator and inhibit platelet aggregation. On the other hand, thromboxane A2 act as a vasoconstrictor and stimulate platelet aggregation. Prostaglandin D2 and E2 are vasodilator and plays an important role in increased vascular permeability and act as a chemotactic agent, PGD2. On the other hand, arachidonic acid, by the action of 5-lipoxygenase, converted into 5-hydroperoxy-icosatetraenoic acid. HPETE stand for hydroperoxy-icosatetraenoic acid, and HETE stand for hydroxy-icosatetraenoic acid. So this 5-hydroperoxy-icosatetraenoic acid converted into 5-HETE, which is a chemotactic agent, and 5-HPETE converted into leukotriene A4, which is further converted into leukotriene B4, which also act as a chemotactic agent. Leukotriene A4 converted into C4, leukotriene D4 and leukotriene E4. They act as a they act as increasing vascular permeability and causes bronchospasm. On the other hand, 5-HPETE, by the action of 12-lipoxygenase, converted into lipoxin A4 and lipoxin B4. They inhibit neutrophil adhesion and inhibit chemotaxis. So these are the arachidonic acid metabolite by the action of cyclooxygenase, prostaglandin produced, and by the action of 5-lipoxygenase leukotrienes produced. Icosanoids bind to G protein coupled receptor and mediate virtually every step of the inflammation. Now we will briefly see the various action of the icosanoids. Vasodilation caused by prostaglandin I2, E1, E2 and D2. Vasoconstriction, thromboxane A2, leukotriene C4, D4, E4, increased vascular permeability, leukotriene C4, D4, E4, chemotaxis, leukotriene B4 and hydroxyicosahexatetraenoic acid. Cytokines, chemokines and complement we will discuss in the separate lecture. In this lecture we will discuss some remaining inflammatory mediators. Other mediators of inflammation, platelet activating factors. They derive from the phospholipid and released by platelet, neutrophil, mast cell, endothelial cell, macrophages and basophils. They act by vasoconstriction and also responsible for bronchoconstriction and responsible for the platelet aggregation. Coagulation products, protease activated receptor got activated by thrombin. They are present on the leukocytes. Kinins, they are vasoactive peptides. The precursor is kininosin, which is high molecular weight kinins, with the help of kallikrein converted into the bradykinin, which is short-lived and inactivated by the kininase. Bradykinin act by increasing vascular permeability, responsible for vasodilation and contraction of the smooth muscle, and plays an important role in pain. Another type of inflammatory mediators are neuropeptide. They secreted by the sensory nerve and leukocytes. For example, substance P and neurokinin A, they produced in CNS and PNS. Also substance P produced by lung and GIT. They act as or play a role in pain signal. They are also responsible for increased vascular permeability. They basically play an important role in crosstalk between nervous system, immune system and inflammatory reaction. For example, in vagus stimulation, whenever vagus is stimulated, it inhibits the pro-inflammatory cytokines like tumor necrosis factor by involvement of these neuropeptides. Now we will see the reaction of inflammation and the various mediators responsible for it. Vasodilation, histamine and prostaglandins, increased vascular permeability, histamine, serotonin, complement protein like C3A, C5A, leukotrienes, C4, D4 and E4. Chemotaxis, leukocyte recruitment and activation. Cytokines like TNF, interleukin 1, chemokines, C3A, C5A, leukotriene B4. Fever, cytokines like interleukin 1, TNF alpha and prostaglandin plays an important role in development of fever. Pain, prostaglandins, bradykinin and substance P responsible for the development of pain. Tissue damage, lysosomal enzymes of leukocytes and free reactive oxygen species of free radical responsible for the tissue damage. So this is the first part of inflammatory mediator. Now in the second lecture we will discuss about the cytokines, chemokines and complement protein and their role in inflammatory, their role as a mediator of inflammation. Thank you. Hello everyone. Now we are going to discuss about the second part of inflammatory mediators, cytokines. So what are cytokines? Cytokines are proteins produced by so many cells, namely activated lymphocyte, macrophages, dendritic cells, epithelial cells, endothelial cell and some connective tissue cells. Cytokines mediate and regulate the immune and inflammatory reactions. Now we will see the cytokines involved in acute inflammation on the heading of source of production of these cytokines and their action. First is TNF, tumor necrosis factor, produced by macrophages, mast cells and T lymphocytes, act via endothelial cell activation of leukocytes. It activates fibroblasts for collagen formation, and in systemic effects it acts as a acute phase response and has an important role in fever. Tumor necrosis factor regulate energy balance by increased lipid and protein mobilization. By this it's suppressing the appetite. In the cases of sustained production of TNF, there will be decrease in appetite, which is seen in some chronic diseases, and this condition is known as cachexia. Another cytokine is interleukin 1, released by macrophages, endothelial cells and epithelial cells. Most of the action is same as a tumor necrosis factor, but it has a more role in fever, development of fever. Interleukin 6, released by macrophages and some other cells. It is particularly important in acute phase response and systemic effects, which we will discuss later on. Interleukin 17, released by the T lymphocytes. It helps in recruitment of neutrophils and monocytes. And the chemokines, secreted by macrophages, endothelial cell, T lymphocytes and mast cell. They help in recruitment of the leukocyte at the site of inflammation. Cytokines involved in chronic inflammation. Interleukin 12, interferon gamma and interleukin 17. First is interleukin 12, secreted by dendritic cells and macrophages. They increase the production of interferon gamma. Interferon gamma is secreted by T lymphocytes and NK cells, and this has an important role in activation of the macrophages. Interleukin 17, released by the T lymphocytes, and it causes recruitment of the neutrophil and monocytes. Now we will see the major role of cytokines in acute inflammation. So first is local inflammation, role of cytokine in local inflammation, like interleukin 1 and TNF alpha, they causes increase in vascular permeability, and they will result into the increased expression of the adhesion molecule on the endothelial cell, and later on endothelial cell will help into the releasing of the chemokines that attract the leukocyte at the site of inflammation. Other effect of cytokines in local inflammation is they activate the macrophages or the leukocytes and further release the other cytokines. In systemic protective effects, TNF, interleukin 1, interleukin 6 will responsible for the development of fever. Interleukin 1 and interleukin 6 will responsible for the production of acute phase protein from the liver, and TNF, interleukin 1 and interleukin 6 will increase the production of leukocyte from the bone marrow. Systemic pathologic effects include cardiac output decreases by the action of the tumor necrosis factor. Tumor necrosis factor are also responsible for the increased vascular permeability, and tumor necrosis factor may cause insulin resistance in multiple tissues. So these are the local systemic protective and systemic pathological effects of the cytokines. Now we will discuss about the another category of inflammatory mediators, chemokines. Chemokines are small proteins of 8 to 10 kilodalton molecular weight. They are chemoattractants for specific type of leukocytes. There are specific type of chemokines for specific leukocytes. Mainly we will discuss about the 4 classes of chemokines: CXC chemokine, CC chemokine, C chemokine, and CX3C chemokine. Here C stands for the cysteine residue. See, in CXC there is one amino acid between 2 cysteine residue. This class of CXC class of chemokine induced by interleukin 1 and TNF. All example of this class of chemokine are interleukin 8, CXCL, also known as CXCL8. They attract neutrophil, monocyte, and eosinophil. In CC chemokine, there are some chemokine known as MCP1, eotaxin, MIP1 alpha. They attract monocyte, eosinophil, basophil, and lymphocytes. C chemokine. Examples of C chemokine are lymphotactin, XCL1. They attract lymphocytes. CX3C chemokine. Example of this class is fractalkine. They attract monocyte and T cells. Chemokines mediate action by binding to G protein coupled receptor. Now we will discuss about the another category and last category of mediators of inflammation known as complement system. Complement system is a collection of plasma protein that function mainly in host defense against the microbes and in pathologic inflammatory reactions. Complement proteins are present in inactive form in plasma. Normally they are present in inactive form in plasma. Critical step in complement activation is proteolysis of C3 or third component of the complement system. Now we will see how many pathways involved in the activation of complement system. First is classical pathway, second is alternative pathway, third is lectin pathway. In classical pathway, binding of C1 to antibody like IgM and IgG, they activate C3 convertase. In alternative pathway, microbial surface molecule or endotoxins or cobra venom, they directly activate C3 convertase. In lectin pathway, plasma mannose binding lectin activate C1, which ultimately activate the C3 convertase. C3 convertase proteolyze C3 into C3A and C3V. C3V form C5 convertase with the help of other complement, and the C5 convertase convert or proteolyze C5 into C5V and C5A. C3A and C5A recruit and activate various leukocytes. This C5B with the help of C6, C7, C8 and C9 form a membrane attack complex, which ultimately responsible for the injury to microbes or the cells or target cells. So this is the complement pathway, complement system activation through classical pathway, alternate pathway and lectin pathway. What are the functions of complement system? There are three major type of function we are going to discuss. First, in inflammation, their role in inflammation, C3A, C5A, C4A, they release histamine, and as we know, histamine plays a very important role in development of inflammation. C5A act as a chemotactic agent. C5A also stimulate the lipoxygenase pathway and result into the production of leukotrienes from arachidonic acid. Another function of complement system is opsonization and phagocytosis. C3V inactive, particularly inactive C3V, act as an opsonin and stimulate phagocytosis or increase phagocytosis. Cell lysis, membrane attack complex, is responsible for killing the microbes with thin cell wall. Now we will discuss about the complement regulator. If complement goes unchecked, it can damage the host cell also. So there are certain complement regulator. First is C1 inhibitor. It blocks the activation of C1. Deficiency of this inhibitor will result into the hereditary angioedema. Other regulator is CD55 and CD59. CD55 inhibit C3 convertase and CD59 inhibit membrane attack complex. Deficiency of these is seen in the condition of PNH, paroxysmal nocturnal hemoglobinuria, which is a type of hemolytic anemia, which we will discuss later on in the hematology. The third type of regulators are complement factor H. They increase the cleavage of C3b and inhibit the alternate pathway. Polymorphism of this factor H gene is result into the age-related macular degeneration. So we have three classes of complement regulator. First is C1 inhibitor. Deficiency of C1 inhibitor will result into the hereditary angioedema. Other is CD55 and CD59. Deficiency of these will result into the PNH. And third is complement factor H. Deficiency of factor 8 or polymorphism or mutation in factor H gene will result into the age-related macular degeneration. So now we have completed the inflammatory mediators. Thank you. Hello everyone. Now we are going to discuss about the chronic inflammation. Chronic inflammation is a response of prolonged duration in which inflammation along with tissue injury and repair coexist at varying combination. What are the causes of chronic inflammation? First is persistent infection with microorganisms. Some of the microorganisms are difficult to eradicate and may result in chronic inflammation. For example, mycobacterium. Hypersensitivity reaction can also result into the chronic inflammation. Prolonged exposure to potentially toxic agent like potentially toxic agent, they can be endogenous or exogenous. In endogenous, cholesterol deposition which is seen in atherosclerosis, and in exogenous toxic agent silica particle can also be responsible for the chronic inflammation. So broadly we have seen three causes: persistent infection, hypersensitivity reaction, and prolonged exposure to potentially toxic agent which can be endogenous or exogenous. Now we will discuss about the morphologic features of the chronic inflammation. Characteristic feature of chronic inflammations are inflammation with mononuclear cells, namely macrophages, plasma cells, and lymphocytes, along with the tissue destruction. Tissue destruction is a feature of chronic inflammation. This can be due to the offending agent or by the inflammatory process itself. And there will be attempts at healing. Body tries to heal the injury via angiogenesis and fibrosis. So these are the three morphological features of chronic inflammation: mononuclear cells, tissue destruction, or attempts at healing. Cells and mediators involved in chronic inflammations. As we have discussed, primarily the mononuclear cells play an important role in chronic inflammation. Now we will discuss them one by one. Macrophages. Macrophages are the dominant cell in chronic inflammation. Macrophages, how they produce? In bone marrow, by hematopoietic stem cells, there is a production of monocyte which ultimately release into the blood, and these monocytes get activated into the macrophages during inflammation or various processes. On the other hand, yolk sac and fetal liver contain some progenital cells, and they form the tissue resident macrophages like Kupffer cells in liver, alveolar macrophages in lungs, and microglial cells in CNS. Half-life of the macrophage. Half-life of blood monocyte is short, normally 1 day, but half-life of these tissue macrophages can vary from months to year. Products of activated macrophages, once get activated, they eliminate injurious agent, play an important role in repair, and may result into tissue injury. One of the very important topic is activation of macrophages. This plays a very important role in inflammation and healing process. So we will see how macrophages get activated. There are two pathways. Classically activated macrophages known as M1, alternatively activated macrophages known as M2. So microbial products like endotoxin or interferon gamma secreted by lymphocytes will result into the activation of classically activated macrophages M1. These classically activated macrophages secrete or produce reactive oxygen species, nitric oxide, and lysosomal enzymes, and will responsible for the microbicidal actions, phagocytosis, killing of bacteria and fungi. And on the other hand, they secrete some cytokines like interleukin 1, interleukin 12, interleukin 23 and chemokines, and further play an important role in inflammation. Now we see the alternatively activated macrophages. Cytokines like interleukin 13, interleukin 4 and interferon gamma, they activate macrophage into the alternatively activated macrophage M2. These M2 type of macrophages secretes growth factors and TGF beta, which plays an important role in tissue repair and fibrosis, and they secrete some cytokines like interleukin 10 and tissue growth factor beta. And as we know, interleukin 10 and tissue growth factor beta has an anti-inflammatory effects. So M2 macrophages has important role in tissue repair and fibrosis, and they have an anti-inflammatory activity. Other cell types in chronic inflammation that play an important role is lymphocytes. Microbes and other antigen activate T and B lymphocyte by various mechanisms, and they play an important role in chronic inflammation. CD4 T cell, known as helper T cell, once activated, they have three classes: Th1 cell, Th2 cell, and Th17 cell. H stands for helper T cell. Helper T cell 1 secrete interferon gamma, which activate macrophages by classical pathway. As we have already discussed about the action of classically activated macrophages earlier. Th2 cell secrete interleukin 4, interleukin 5 and interleukin 13. They play an important role in recruitment of the eosinophil. They activate macrophages by alternatively activating pathway. Third type of CD4 T cell is Th17 cell. They secrete chemokines and responsible for the recruitment of neutrophil and monocytes. This is a diagrammatic representation of macrophage lymphocyte interaction in chronic inflammation. Antigen presenting cell react with the T helper cell, CD4 cell, and after activation CD4 cell secrete interferon gamma, which convert monocyte into the activated macrophages by classical pathway, and these activated macrophages secrete interleukin 12, which further activate Th1 cell, and they keep complementing each other's function, and activated macrophages may result into the formation of the granuloma. So this is a diagrammatic representation of a granuloma, which we will discuss later on. Another cell type is eosinophil. Eosinophil is particularly important in allergies or parasitic infection. Eosinophil has major basic protein, a cationic protein, which is toxic to parasitic infections. Mast cell. They are widely distributed in connective tissues and participate in both acute as well as chronic inflammation. Mast cell secretes variety of cytokines mast cell. They bind with the Fc portion of the IgE immunoglobulin and release mediators like histamine and prostaglandins, and take part in inflammation or responsible for the development of inflammation. Neutrophils. In chronic bacterial infection like osteomyelitis, neutrophil can be a predominant cell. Now we will discuss about the granuloma or granulomatous inflammation. Granulomatous inflammation, one of the very important topic. Granulomatous inflammation is a form of chronic inflammation. It is a type of chronic inflammation. Granuloma formation is a cellular attempt to contain an offending agent that is difficult to eradicate, which cannot be eradicated so easily. So it is an attempt to contain that offending agent, like seen in Mycobacterium tuberculosis, which is difficult to eradicate. Normally, granulomatous inflammation associated with the normal tissue injury or injury to the adjacent normal tissue. How granuloma develop? Activated macrophages has abundant cytoplasm and they resemble like an epithelial cells. That's why they known as epithelioid cells. Activated macrophages may fuse to form a multinucleate cell, which is known as giant cell. Granuloma can be of two types: foreign body granulomas or immune granulomas. Foreign body granuloma is incited by inert foreign bodies, which result into the inflammation. There is absence of T cell mediated immune responses. On the other hand, immune granulomas, variety of agent causes persistent T cell mediated immune response, and they are difficult to eradicate. T helpers lymphocyte get activated by the antigen presenting cell and secrete interferon gamma. These interferon gamma activate macrophages by classical pathway into M1 macrophages. In some parasitic infection, helper 2 cell Th2 cell also responsible for the development of granuloma, which is seen in schistosomiasis. Now we will see the morphology of granuloma. Here we are taking example of caseating granuloma, which is seen in Mycobacterium tuberculosis. A center portion of necrosis surrounded by epithelioid cells, epithelial-like activated macrophages, epithelioid cells with the collar of lymphocytes and fibroblast and giant cells are also noted at places. The central portion of necrosis is because of the hypoxia and reactive oxygen species. Examples of granuloma, one of the very famous example is tuberculosis, leprosy. Granulomas can be seen in syphilis, cat scratch disease, sarcoidosis and Crohn's disease, which is a form of inflammatory bowel disease. Hello everyone, now we will discuss about the systemic effects of inflammation. Inflammatory cells secrete various cytokines like TNF, interleukin 1, interleukin 6 and interferon. They may result into the acute phase response. Acute phase can be in the form of fever, increased level of acute phase protein, leukocytosis, hypertension and increased pulse rate, or sepsis in severe bacterial infection due to the excessive release of interleukin 1 and TNF. So first is fever. When body temperature increases by 1 to 4 degrees centigrade from the basal temperature, most prominent manifestation of the acute phase response is fever. Pyrogens are the substance that responsible for inducing fever. They can be exogenous or endogenous. In exogenous pyrogens, bacterial products that stimulate the immune cell which secretes cytokines like interleukin 1 and TNF, and in endogenous pyrogens are these cytokines like interleukin 1 and TNF which stimulate the vascular and perivascular cell of the hypothalamus and release prostaglandin E2. This prostaglandin E2 by various neurotransmitters increases the body temperature via decreasing heat loss through vasoconstriction or heat generation through brown fat and skeletal muscle. NSAIDs are the drugs. They inhibit the release of this prostaglandin E2 and thus prevent development of fever. Increased level of acute phase protein. They are plasma protein synthesized by liver. By the action of cytokines like interleukin 6, 1 and TNF, liver produce some acute phase proteins like CRP, fibrinogen, amyloidotic protein and other proteins like hepcidin, thrombopoietin. CRP secreted with the help of interleukin 6 has a property of opsonin. They are the marker of increased risk of myocardial infarction. Fibrinogen is released by the action of interleukin 6 on the liver, and they are responsible for the red cell Role formation, and by Role formation there will be increase in the erythrocyte sedimentation rate. SAA, interleukin 1 and TNF responsible for the increased production of serum of amyloidotic protein. This also acts as an opsonin and seen in chronic inflammation. and responsible for the development of secondary amyloidosis. Other proteins are hepcidin and thrombopoietin. Hepcidin decreases the iron absorption and ultimately decreases iron availability to the erythroid precursors and responsible for the anemia of chronic disease or anemia of chronic inflammation. Thrombopoietin acts as a growth factor for megakaryocyte and increases the platelet count. Leukocytosis is increase in WBC count. In bacterial infection, cytokines like TNF interleukin 1 stimulate bone marrow for the production of more and more granulocytes to combat these infections. In viral infection, there can be a lymphocytosis, and in helminthic infestation, there will be eosinophilia. Leukopenia or decrease in leukocyte count can be noted in certain infection like typhoid fever or rickettsial disease. Increased blood pressure or hypertension or pulse rate can be noted in acute phase response. This is because of the blood redirection from cutaneous to deep tissue. Thank you. Hello everyone. Now we will discuss about the tissue repair. Repair or healing is the restoration of tissue architecture and function after an injury. So after an injury, restoration of tissue architecture and function is known as repair or healing. Repair, usually the term repair used for parenchymal and connective tissue restoration, and the term healing used for surface epithelia restoration. Repair can be achieved by regeneration or scarring. In regeneration, some tissues of the body are able to replace the damaged component and return to the normal state. Like after an injury, the remaining cell of that particular organ proliferate and replace the damaged cell, or local tissue stem cell proliferate and restore the normal state of that tissue or organ. On the other hand, in scarring, when the injured tissue is incapable of regeneration, then there will be scarring. Then repair done by fibrosis, meaning deposition of the collagen, and it provides the structural stability. A term organization stands for fibrosis develops in tissue spaces occupied by inflammatory exudate. Whenever a tissue space which is filled with or occupied by inflammatory exudate, whenever a fibrosis sets in such spaces, this is known as organization. This is the diagrammatic representation which depicts in mild or superficial injury there will be a regeneration or replacement of this denuded epithelial lining, and in severe injury, as we can see, the deposition of fibrous tissue and fibroblast in scar formation. Cell and tissue regeneration. Now we will discuss in detail about the cell and tissue regeneration. A growth factor stimulates stem cells to produce new progeny or for cell proliferation, or result in cell proliferation. Integrity of extracellular matrix is very essential in regeneration. There are some principles that we need to know of cell proliferation. General principle of cell proliferation. First is we will see in cell proliferation there is a mechanism of signals and control. Several cell types proliferate during repair, like remnants of the injured cells to restore the normal structure, vascular endothelial cell, they form new blood vessel for the nutrient supply, and the fibroblast to lay down the collagen or scar formation. So these three types of the cell which proliferate during the repair process. The ability of a tissue to repair is determined by two factors. First is intrinsic proliferative capacity of that tissue or cell, and second is presence of tissue stem cell. So the ability of tissue to repair is determined by two main things. First is intrinsic proliferative capacity, second is presence of tissue stem cell. Based on these two categories, or based on these two things, tissue of body are divided into three groups: labile tissue, stable tissue, or permanent tissue. Labile tissue, they are continuously dividing tissue. Because of the continuous loss, they need to replace the lost tissue with the normal cell. Tissue stem cells play an important role in labile tissue. Examples of labile tissue are hematopoietic stem cells in bone marrow, surface epithelia of oral cavity, skin, vagina, and cervix, cuboidal epithelia of the duct of exocrine glands, columnar epithelia of GIT, uterus, fallopian tube, and transitional epithelia of urinary tract. These all are the example of labile tissue. They continuously divide to replace the lost cell, and tissue stem cells has very important role in labile tissue. Now the second category is stable tissue or stable cells. Normally the cells is present in quiescent stage or G0 stage of the cell cycle. In stable tissue, they have a very minimal proliferative activity, and they are capable of dividing, but only in response to injury. Examples of the stable tissue are parenchyma of the most solid organ like liver, kidney, pancreas, endothelial cells, and fibroblast, and smooth muscle cells. They also are the example of stable tissue. Now the third group is permanent tissue. They are usually terminally differentiated and do not have the capacity or ability to divide further. Examples of permanent tissue is majority of the neurons, cardiac muscle cells, and skeletal muscle cell. Although a satellite cells which is attached to endomysial sheath in skeletal muscle provides some regenerative capacity to the skeletal muscle. So these are the three main tissue type in the body: labile, stable, and permanent, on the basis of their ability to repair. Growth factor and extracellular matrix stimulate various signaling pathways which result into the DNA replication and the biosynthesis of the various cellular component, and this will result into the cell proliferation. Growth factor mostly secreted by macrophages, epithelial cells and the stromal cells. Now we will see, after the cell proliferation, tissue regeneration. We will discuss about the liver regeneration. This is a prototype example of tissue regeneration. Liver cells have the high capacity to regenerate, and how this regeneration takes place. Proliferation of remaining hepatocytes. After the injury, proliferation of the remaining hepatocyte, which follow three phases. First is priming of the hepatocyte. How this priming of hepatocyte occur? Kupffer cells, macrophages, local macrophages of the liver release interleukin-6, which make hepatocyte competent to receive and respond to growth factors. So in priming of hepatocyte, interleukin-6 plays an important role. The next phase is growth factor phase. Hepatocyte growth factor and TGF-alpha stimulate primed hepatocyte and promote primed hepatocyte, then enter into the cell cycle from quiescent stage and result into the hepatocyte proliferation. Proliferation of Kupffer cells, endothelial cell, satellite cells will also noted after the hepatocyte proliferation. Now third phase in regeneration is hepatocyte return to the quiescent stage, and in this phase TGF beta plays an important role. In liver regeneration, we have discussed about the proliferation of remaining hepatocyte in three phases. Phase 1 is priming of hepatocyte, phase 2 is growth factor phase, and phase 3 is termination phase. And on the other hand, a regeneration can takes place by a repopulation of hepatocyte from the progenitor cells. In chronic liver injury and inflammation, hepatocyte proliferative capacity usually decrease very severely and they cannot regenerate. In that case, some progenitor cells in liver that present in the canal of Herring repopulate and repopulate and fulfill the demand of the damaged cells. So this is the tissue regeneration we have discussed, particularly in the setup of liver injury by proliferation of remaining hepatocyte or by repopulation from the progenitor cells. Restoration of normal tissue structure can occur only if residual tissue is structurally intact. This is a very important line. If the residual tissue is structurally intact, then only the restoration can occur. The structural integrity of residual tissue is very important for the regeneration or restoration of the normal tissue structure. Now we will see the repair by connective tissue deposition. If repair cannot be accomplished by regeneration, then what happens? The connective tissue deposition will be there, and there will be a scar formation which provide an structural stability. Now we will discuss about the steps involved in scar formation. First of all, there will be injury along with the inflammation, which result into the cell proliferation of epithelial cell proliferation, endothelial cell proliferation, and fibroblast proliferation by various cytokines and growth factor. After the cell proliferation, there will be a formation of granulation tissue. Granulation tissue composed of fibroblast, delicate capillaries, loose extracellular matrix, and mononuclear cell, mainly macrophages. Deposition of connective tissue. The next step of scar formation after the granulation tissue formation is deposition of connective tissue on this granulation tissue, and this will result into the fibrous scar formation. Alternatively activated macrophages, M2 macrophage, clear the dead tissue and offending agent, and they secrete growth factor and cytokine, which will result into the proliferation of fibroblast, and fibroblast will result into the deposition of connective tissue like collagen. The steps involved in the formation of granulation tissue and scar. First is angiogenesis. Angiogenesis is synthesis of blood vessel. Second is deposition of connective tissue, and third is remodeling of that deposited connective tissue. So we will discuss them one by one. First is angiogenesis, a new blood vessel development from the existing blood vessel. Now there are some steps in the development of angiogenesis. First is there will be a vasodilation and increased vascular permeability. Vasodilation mediated by nitric oxide, and increased vascular permeability due to VEGF, vascular endothelial growth factor. After the vasodilation, there will be a separation of pericyte and the breakdown of basement membrane, and there will be this is the vasodilation, and after the vasodilation there will be a separation of pericytes, and breakdown of basement membrane will result into the a basal sprout from the main blood vessel. This is a basal sprout. Endothelial cells then start migrating toward the areas of tissue injury in this basal sprout. Proliferation of these endothelial cells takes place. After the proliferation of these endothelial cells, there will be a remodeling into capillary tubes and recruitment of the periendothelial cells, pericyte and smooth muscle cells. And lastly, the suppression of endothelial proliferation, migration and deposition of basement membrane. This is a diagrammatical representation. This is a quiescent vessel. So for the angiogenesis, there are some mediators like nitric oxide and VEGF. They result into the increased vascular permeability or vasodilation. After the vasodilation, there will be a sprout formation, a new blood vessel. This we can see. Pericyte detachment is important for this basal sprout. Subsequently, these basal sprout elongated by various signals and form a new blood vessel by the proliferation of endothelial cell, the proliferation of endothelial cells, pericytes. Now we will see the various mediators and their role in angiogenesis. VEGF-A, this plays an important role in migration and proliferation of endothelial cells. FGF2, this will result into the increased proliferation of endothelial cells. Angiopoietin 1 and 2, they are responsible for the structural maturation of the new vessel. PTGF, this will be responsible for the smooth muscle recruitment. TGF beta, this inhibit the endothelial cell proliferation and migration. This will help into the remodeling and also responsible for the production of extracellular matrix. VEGF stimulate notch ligand on the endothelial cells, which further stimulate the notch receptor, and through a notch signaling pathway, sprouting and branching of the new vessel occur. So these are the various mediators and their role in angiogenesis. Now the second stage. Now the second step, as we have covered the angiogenesis, second step in granulation tissue and scar formation is deposition of the connective tissue. So there are two steps in deposition of connective tissue. First is migration and proliferation of fibroblast. Second is deposition of extracellular matrix protein by these cells. PDGF, FGF2, TGF beta, they are released by the alternatively activated M2 macrophages. TGF beta is the most important cytokine for the deposition of connective tissue proteins. The third step in granulation tissue and scar formation is remodeling of the connective tissue. After deposition of connective tissue, there will be remodeling of this connective tissue by matrix metalloproteinases. They are zinc based enzyme. Broadly they have three categories: MMP 1, 2 and 3, which will be responsible for the remodeling of fibrillar collagen. Gelatinases, which will be responsible for the remodeling of amorphous collagen, and fibronectin. And third is stromylysins. They modify or remodel laminin, fibronectin, amorphous collagen and proteoglycans. There are tissue inhibitors of matrix metalloproteinases. They inhibit the functioning of matrix metalloproteinases. Now we will see the factors that can influence or affect the tissue repair. First is infection. Infection of the injured site can result into the delayed tissue repair. Diabetes can also delay the repair of the tissue. Nutritional status, deficiency of protein and vitamin C will also result into the delayed healing, as these are very important for the connective tissue deposition. Glucocorticoid inhibit the TGF beta. TGF, as we know, TGF beta is the most important enzyme for the deposition of connective tissue. Mechanical factors like If the site of injury is under pressure or tension, then this will also result into the delayed tissue repair. A foreign body present at the site of injury or site of repair will further hamper the process of tissue repair. Poor perfusion of that site is also an factor that can delay the tissue repair. Type and extent of tissue injury and tissue. As we have discussed, there are three types of tissue: labile, stable and permanent. On the basis of their capacity to regenerate, the tissue repair will occur. Or this also based on the type of tissue injury. If there is a severe tissue injury, this will also result into the delayed healing or somewhat healing by the scar formation. Location of the injury may also play an important role in tissue repair. Now we will briefly discuss about the abnormalities in the tissue repair. So first is the defect in healing. If the healing is delayed, this will result into the development of chronic wounds like venous leg ulcer, arterial ulcer, diabetic ulcer and pressure sores. On the other hand, excessive scarring will result into the hypertrophic scar or keloid formation. In hypertrophic scar, the original wound is within the boundaries of the scar is within the original wound, but in keloid, scar tissue grows beyond the boundaries of the original wound and it usually does not regress. So thank you for your time.